My name is Frank Butler. I am a retired Navy doctor. The story of whole blood in the U.S. military is just remarkable. We discovered that it was the best thing to use to resuscitate casualties in World War I. And then after the war was over, we had a peace interval and the military shifted away from whole blood to thinking that plasma was the best thing for medics to use. It was definitely more logistically easy to use, but it didn't work as well. And we didn't find that out until World War II, when some of the American surgeons, notably Colonel Pete Churchill, noticed that the American casualties who were getting plasma were not doing as well as the British casualties who were getting whole blood. So he tried to convince the Army to go back to whole blood, which they ignored. So he told that story to the New York Times, and they published it. And all of a sudden, the Army did decide to go back into using whole blood. Unhappily, after World War II, we again forgot that whole blood was the best thing to use. And when we went to war in Afghanistan, nobody in the U.S. military pre-hospital was carrying blood to use to resuscitate casualties. They were carrying colloids and crystalloid fluids, which just don't work as well. And over the course of the war, leaders like Colonel Cap, Colonel Don Jenkins, Colonel John Holcomb began to move back towards whole blood. At first, they were using red blood cells in a more balanced fluid resuscitation plan than they had been in the past. Previously, there was much more red blood cells given than there was plasma. And if you have somebody who is bleeding to death, the plasma helps their coagulation to work and save their lives. So you need to make sure that plasma is given as well as the red blood cells. And after a few years of that, the next step was to realize, hey, what we really need is whole blood. Even though it had been used in conflicts like Mogadishu, there was really no organization-wide preparation for whole blood, but it began to be used by some hospitals and then became widespread as papers were published that documented that whole blood was better than crystalloid fluids and at least as good as component therapy. And then finally, Colonel Stacy Shackelford and Colonel Jen Gurney wrote papers that documented that the sooner you get the whole blood into the casualty, the better they do. So if somebody's in shock and you wait an hour or two to start their fluid resuscitation, that's nowhere near as good for them as if you start their fluid resuscitation right away. It makes common sense, but it wasn't documented until those papers came out. And so now the push is to have pre-hospital medics and pre-hospital people in the civilian sector as well, carrying at least a couple of units of low titer O whole blood. The low titer O whole blood is a universal donor product so that you can give it to anybody without having a major hemolytic reaction. The military has made the decision to use TC3. So I think if you're a military EMS director, it's absolutely imperative that you read PHTLS 10 so that you can understand why you're using pre-hospital whole blood, why you're using combat gauze, why you're using interosseous access device, which IO access device should I use, which tourniquet should I use. All of those things are critical. In the civilian level, or in the civilian sector, you have EMT basic, advanced, and then paramedics. Anyone who is a medical director who provides instruction for those medics has to know about TC3. That doesn't mean that every military or every civilian sector has to adopt everything in TC3 at all, but they absolutely should look at it and say, yes, I'm going to do this, or no, I'm not going to do this. And in the military, we have adopted TC3 as an entirety, as a single body of knowledge and a single set of recommendations. It's different in the civilian sector. In that environment, each EMS system makes its own decision about each life-saving intervention. So you could have an EMS system, and there's many systems like this that currently use tourniquets but don't use pre-hospital whole blood. And it's important for those medical directors on both sides to look at the evidence that supports pre-hospital whole blood before they make a decision not to use it. So, yeah, I mean, this is something that's been very successful in the military. If you are a civilian medical director, it seems to me that it would be imperative for you to be able to make an informed decision, that you have read the military experience and can say yes or no based on your thorough reading of what's in PHTLS 10 military.